Good morning, good afternoon, and good evening to all my friends, colleagues, panelists, and delegates of today's session of ACNS YNS webinar series. And as usual, that this webinar series is dedicated for the education, especially for the young neurosurgeons of low and low resource countries. And today we have yet another interesting webinar wherein we have a special guest speaker, Professor Mustafa Baskaya, who's well known for his vascular work, who's a professor and the Robert J. Dempsey Professor of Neurological Surgery at University of Wisconsin School of Medicine and Public Health, USA. And along with that, we'll have another YNS speaker, who's our a member of our ACNS YNS committee, Dr. Meshari Rashid Al-Hutai, who's from Saudi Arabia. And to Professor Yoko Kato as our chief patron, who's the president of ACNS Society. And to chair this session, we have our education team member, that is Professor Abida Shah, who is the assistant professor neurosurgery at St. G.S. Medical College and KEM Hospital, Mumbai, and discussant our Professor Fawad Pirzad, who is the president of Neurosurgical Society of Afghanistan, and Professor Ibrahim, who is the president of Association of Neurosurgeons in Bosnia and Herzegovina. Now, to start with, I think Professor Baskaya has not yet joined, so we'll start with our YNS talk, and he's going to present a very interesting topic, that is surgery went on well, but however, something happened. So over to you, Dr. Meshari Rashad Al-Hutai. He is a neurosurgery specialist and neuroscience center, King Faisal Specialist Hospital and Research Center, Kingdom of Saudi Arabia. I would request Professor Dr. Meshari to please share his screen and start his talk. But before that, I would request Professor Yoko Kato to say a few opening words and a few opening words from our chairperson, Dr. Abida Shah. First, Professor Yoko Kato, please.
Okay, thank you very much, everybody. Welcome to our June YNS webinar. Thank you very much for joining and prepare your presentation. I'm very much looking forward to your lecture, and also I heard a lot from the Imad Canon about you. So please start your lecture. And also the Abida Shah.
Thank you. Thank you, Professor Kato, for this wonderful webinar series, and thank you, Sachin, for conducting it so beautifully. And this is yet another exciting episode of the YNS. I have attended many now, and I'm grateful to everyone who has attended, and thankful to the speakers for sharing their neurosurgical work with us, and let us all learn together. Go ahead, Dr. Meshari.
Right. So thank you very much, Dr. Abida Shah. Just to mention, I forgot to mention, Dr. Ben and Dr. Liu are my co-hosts today. So Dr. Ben is also there. So Dr. Meshari, please start your presentation.
Okay. So hello everybody, my name is Meshari Hadel. I'm a neurosurgeon from King Faisal Specialist Hospital Research Center in Riyadh, Kingdom of Saudi Arabia. I'm very happy to be able to present today. It's a true privilege. I would like to thank the organizing committee and to thank Professor Kato for her continuous support. So as the title indicates, today my talk will be basically about complications in neurosurgery, and more precisely about postoperative complications. So I'll go through a small introduction about complications in neurosurgery, then I'll take you through a case of our own where we had a very unique kind of complication, and I'll show you what we did to help that patient. Then I'll give you a small review about that specific complication. So before I start, I'd like to share this quotation with you. You know, luckily, Professor Jack Marcus, just 48 hours ago, published an article about complication in neurosurgery. He called it Forgive and Remember. And in that article, he was showing us his experience on how to avoid complications and what to do to prevent them from happening again and how to cope with them. And from his article, I quote, he says, if there ever was a time to do it, and he's referring to a good communication with the patient and his family in the event of complication. This is when you sit on the bed next to your patients, comfort them with a hand on their shoulders and a warm smile. They have let you cut into their brain. They now more than ever yearn for you to speak to their hearts. So to start with, the definition of complication or postoperative complication is basically any deviation from the normal postoperative course occurring within the first 30 days of surgery. And one of the very common classification system is Landriel, where there are 4 grades. Grade 1, when there is a non-life-threatening complication that required no intervention. And grade 2, when an intervention, invasive intervention was required. Grade 3 is when you involve an ICU in the management of that life-threatening complication. And grade 4 is basically a mortality. So I have reviewed a few articles about the complication neurosurgery. One of them is the one done by Rock and his group, and in their article they have reviewed more than 175,000 neurosurgical cases, including spinal and cranial cases. And in their review, the complication rate was around 13.5, and the mortality was 1.5. And then they have analyzed the differences between cranial and spinal cases, and they have identified that mortality was actually higher in cranial cases. However, the rate of every other or all other complications were lower in the cranial case compared to the spine. And this is a list of the possible postoperative complication. This was published by Wong and his group in 2012. And in this article, they reviewed the pattern and the neurosurgical complication specifically for intracranial neoplasm surgery, including intraaxial and extraaxial. And DVT was the most common complication observed, followed by neurological deficits. And this is the list of the remaining complications that they have or they were able to review. Now, one interesting aspect in complication neurosurgery, and you will find a few articles in the literature, is the involvement of the residents and trainees in the operating room. And Lem and his group have reviewed that, and they did a retrospective study where they included more than 8,700 patients, where residents were involved in 50% of the cases. And they have actually concluded that there was no significant impact in the involvement of residents and trainees and the development of postoperative complication. And this conclusion, you will find this conclusion on many other similar articles, and they have even with considering the difference during the year, beginning of the program and the end of the program. Now, before I take you before I take you through our case presentation, let me share with you a few points that I have learned from our mentors and patients. In order to be able to avoid complication, or in order to have a career in neurosurgery, I don't think you will be able to have a career without having to face complications. And the important thing is to know how to face it, to deal with it, to prevent it in the future, and to be there for your patient, and to be prepared to emotionally cope with it and be ready for your next patient to give him your 100%. And one of the skills that I have learned from my mentors, from Dr. Kanaan, is the skill of rehearsal. Before any case, before going to any OR, I always do that case in my mind first. I go to the OR in my mind and look at the surgical setup in my mind, talk to the scrub nurse, position the patient, do the skin marking, do the opening, dissect the lesion and remove it, look at the surrounding structure, and talk to the anesthesia, and close and wake up the patient, all in my mind before going actually to the surgery. And anticipate, look for the potential pitfalls, the possible complication, deal with them in your mind before going to the OR. See what do you need to deal with them and what kind of complication might appear. If you do this, the chance of you being surprised in the OR would be lower. The chance for you to have to stop and think in the OR during stress will be lower. And if you lower these chances, your safety profile will go higher and you will benefit your patient more. Also, another important point is to prepare your patient really well. From workup point of view, if your patient needs a vascular image, do it. Don't rush a case just to use the OR time. Do an occlusion test if you need. Be ready physically and mentally. Be prepared to face a complication and prepare your patients as well. Use every surgical tool you need to ensure safety of the procedure. You can use navigation, microscope, endoscope, all of them, ICG, and learn from your mistake. I think the very important point is never repeat a preventable mistake. And good communication skills actually sometimes is more important than your surgical skills. Be honest, talk to your patient and his family about the case, about the possible complication. Talk to your colleagues, prepare them, starting from your nurses in the OR and your anesthesia team. During the time of stress, when you face a complication, know how to talk to your senior neurosurgeon. Ask him for help. talk to your intervention radiologist, know how to say it, what to say in the shortest possible period to deal with that difficult situation. And now allow me to take you through a case presentation. This case was actually published and I will show you a very specific complication and how we manage that complication in a technique that was not really well described in the literature. And we had this lady who is a 53-year-old diagnosed with epilepsy or multiple epileptics. She was seen at her local hospital after she presented to them with a progressive chronic headache. And when they did the image, they found that this lesion and they referred her to us. As you can see in the MRI, this lady is suffering from a posterior fossa meningioma on the right side with attachment to the tentorium, to the posterior dura, and to the falx cerebelli, and it's very close to the transverse sinus and the trochlea. The MRV shows actually the ipsilateral transverse sinus being the prominent one. So we sat with the patient, we offered her surgery, we counseled her well, we gave her all the possible complication as well. Then we booked her for OR. And here you can see the position that we choose. You can do this case with a simple prone position, but we like the lateral position to use the gravity to maintain a dry field. And now I'll take you through the case very quickly. This case was done along with Professor Ahmad Kanan. So this is the microspitzer suction that we used. This, in addition to the position, will help you maintain a dry field. So this is a case of meningioma that was resected basically using the basic principle of meningioma, including devascularization, then debulking, and then dissection, followed by basic removal of the lesion. We had no difficulties in the and we had no major events inside the surgery. For the sake of time, I will go to the next. This is the post-operative MRI. In the MRI, you can see an adequate removal of the lesion. We might have left a thin layer of the lesion very close to the venous structures. Now, post-operative course was really uneventful. She was extubated in the OR and sent to the ICU, where she stayed there for 1 day. Then she was shifted to the neurosurgery ward. She was able to walk and talk and eat without any deficits. Her pathology was grade 1 meningioma. So at this stage, you are starting to think, when should I discharge this lady? And what kind of follow-up plan should I do? However, remember that progressive disease is not suspended between 5 p.m. and the morning rounds. And you have to be sharp and focused for your patient 24 hours. And you have your performance at 8 p.m. has to match your performance at 8 a.m. So what happened to this lady is on day 2 post-op, we received a call from the primary nurse that the patient is suffering from severe headache and vomiting, and she's not really walking anymore because of headache. Then we went to the patient. Only in your way to the patient, you have to brainstorm what could be the problem. Does she have now hydrocephalus? Or is there any hematoma in the surgical field? We were very close to the sinus. Is there any sinus thrombosis? She was already started on heparin, and she's on dexamethasone, a very adequate dose, and already on antiepileptics. Could this be just a seizure? Because she has a history of seizure. So once you reach that patient and you are sure that she's stable and she can go to CT, you send her for a CT. In the CT, you can see that there is actually a supratentorial hydrocephalus. And then the CTV was really unremarkable. So she had a hydrocephalus. We booked her for emergency EVD, and EVD was inserted uneventfully. Post-operatively, she was back to baseline. And 2 days later, at that EVD, I mean, this is not the complication I want to show you. I'm not going to keep you waiting just to see hydrocephalus, but 2 days later, the EVD was not really draining well. And the patient again started to complain of headache, requiring frequent PRN. Her headache prevented her from walking around the ward. So if you go back to the coronal CT, you can see that the tip is very deep in the third ventricle. So we thought maybe the third is collapsing against the EVD tip. Maybe if we just pull it 2 centimeters, we'll optimize its position, and that will help the patient. And we did that, taking all precautions. She was supine, we clamped the EVD and everything. And we did that. 3 hours later, she dropped out of consciousness and started to have anechoic pupils. And now this deterioration is far worse than the one she had earlier. So again, you rush to the patient, the rapid response team are along with you by the bedside, you stabilize the patient, then you send her for imaging. To be honest, at this point, the first thing that came to my mind is she must have had a hematoma because of us pulling that EVD, an IVH, and that has caused the EVD not to drain any further. But that was not the story. So this is her immediate CT. What you can see here is that the patient now is having a tension pneumoventricle, an intraventricular pneumosyphilis that caused a significant mass effect and dilatation of the ventricles. So now what to do? Should you just put her on 100% non-rebreather mask and leave her in ICU? Of course not. You have to take her to the OR. This patient is already deteriorating because of this high ICB. So we took her to the OR and we did what we call a water-sealed pneumoventricular evacuation. I'll talk about the technique in the coming few slides. Basically, we changed the AVD and we dropped the other end underwater, and you can see the bubbles coming out with each heart rate. And this amount of air is the one causing the pneumoventricle. And I'll talk later about how we do it exactly. But we tunnel the AVD at the end through another route, and we seal it well. Once you see a pneumoventricle, you have to look for the source as well, because you have to correct that at the same setting. Otherwise, she will reaccumulate. Now, we had to look back and think what caused this pneumoventricle to develop. We looked at our CT. We were very far from the air cells. And we examined the AVD in the OR before we remove it. And there was no holes in it, because we thought maybe with the anchoring suture we might have injured the AVD. But our conclusion was that when we released the anchoring suture to modify the AVD position, we must have allowed a cutaneous ventricular fistula, and the air started to leak. You can see the trace of air around the AVD, and then it was trapped in the ventricle and sealed the exit and caused this trapped tension in the ventricle. Patient did well post-operatively. She showed immediate improvement, and now she had only a small amount of pneumoventricle. We left the AVD for a few days, then we challenged it and removed it. She did not require any permanent shunting, and she did not have any added neurological deficits. And this is her post-op CT just before she was discharged home. Now I'll take you through a few slides about tension pneumoventricle. This is a very rare, however, very serious and potentially life-threatening complication. And when we reviewed the literature, we were able to identify patients at risk. The most common cause of this is actually trauma, specifically scalp fracture, where air sinuses are involved. Because if you have this, then you have a source of air to leak inside. Post-operative patients, specifically posterior fossa surgery or sitting position, are also potential risk. Congenital skull defect like encephalocele. Positive pressure, barotrauma, and mannitol are potential risk factor, provided that the patient has a source for air to leak in, because these will cause the air to forcibly go intracranially. Now, the theories or the pathophysiology for this is not new. Dandy described the ball valve theory in 1926. And this is the drawing from his original article. This is how they identified the tension in the ventricles. And this is his description of the intraoperative finding when he opened the dura. Then after he basically deflated this pneumoventricle, he was able to identify the source. This is a patient who had a trauma, and this opening is through the frontal air sinus. So there was an opening through the frontal sinus, opening in the dura, and the cortical injury as well. And what he was trying to say that if you have a source of air to leak intracranially and you have a dural opening, whenever the patient has valsalva or forceful coughing or sneezing, air will travel forcibly through the dural opening into the intracranial cavity. Now, trauma patient might have an axonal injury or encephalomalacia. This might create a path toward the ventricles and let the air into the ventricle cavity. Then Hertz had the inverted soda bottle on 1964, and this is the drawing, again, original from his article. In this patient, they had a mastodorsal injury because of a trauma. And in his article, he was trying to describe that basically a temporary intracranial negative pressure will cause the air to leak from the source intracranially. And there is a difference in pressure from horizontal or supine position to a standing position. And EVD and VB shunt does basically this phenomenon. When you have an EVD or a VB shunt, this can cause an intracranially negative pressure sucking the air from the source, the mastodorsal in this case. And once that happens, we go back to the ball valve theory. Air leaks in, causes a mass effect, the brain descent and seal the entry point and cause a trapped tension pneumoventricle. So with regards to symptoms, basically there are symptoms of high ICB. However, these patients can deteriorate really rapidly. might have decrease of consciousness, headache, vomiting, CSF leak, and pruihydroic, which is basically splashing sounds of air leaking inside. Now, the management is really dependent on early recognition. Once you have a patient who's deteriorating, you obviously assess him, make sure he's stable, then you send him to CT. Once you look at the CT and find this picture, tension in the ventricle, always look for the potential source, whether it is from the skin, whether it is from the posterior fossa wound, or in case of trauma, a potential air sinus involvement. And don't rely on the existing AVD. Once you get a call about a deteriorating patient and you know that he has AVD, you might have a sense of safety. This sense of safety can lead to trouble, especially in this case, because this AVD, even if you attach it to an ICP monitor, it will not show you high ICP. This has been documented in the literature. And if you see this as well, you have to decide that this is a case that needs surgery, and surgery immediately. And you decompress the air and correct the potential source. Now, with regard to the technique, what we did usually, basically, is we took the patient, we removed the AVD that she has, and put a new one through the same burr hole without the stylet. It was just soft pass. Once we did this, we had the gauze on the top of the burr hole, soaked gauze to isolate. Then we drop the other end underwater. Once you do this amount of air that comes at the first is the one that's causing the high ICP. This is what caused the tension in the ventricle. Once bubbles stops, then you have converted this tension in the ventricle into a regular pneumoventricle. Then at this point, you can replace that air with a normal saline. You can have a syringe and inject inside through through the AVD. Then again, drop the AVD down underwater at the level of the tragus or Lowell. Then the saline will just replace the air. Then after that, you use another tract to tunnel the AVD out and seal the other one really well and repair the source of the ventricles if it's different than this. If the patient has frontal air sinus fracture, you have to cranialize it. You have to treat it before you stop the surgery, because otherwise she will reaccumulate again. Now, the take-home message is that tension in the ventricle is rare, but very serious complication and life-threatening at some times. Recognize patients at risk. Don't rely on AVD because it might mislead you. Surgical decompression and source control has a good outcome if they are done on timely fashion. A wise surgeon once said that a true surgeon is never fearless. He fears for his patients. He fears for his shortcoming, his own mistake, but he never fears for himself, nor for his professional reputation. Do the best and your best for your patient. And I'll conclude with this photo of our beautiful city of Riyadh. And this is King Faisal Hospital, the hospital I work for. And with that, I thank you for your attention.
So first of all, it was a very interesting presentation and very innovative technique of treating a tension pneumoventricle. After that, I would apologize, Professor Mustafa Baskaya, that since we did not see you there in the screen, maybe my mistake that I could not find you. We had taken our second speaker, that YNS speaker, talk first. Now it's good that we have you here, but please participate in the discussion. And I would request our chairperson, that is Professor Abida Shah, to please make comments about Dr. Meshari's presentation.
Dr. Meshari, that was a really interesting presentation. It is quite surprising that the air tracked around the EVD, because we use EVD routinely in many cases and we rarely see this kind of a complication. Normally what we do is just tap suppose there is a pneumoventricle, we just tap it and then remove we don't leave the thing inside, because once the air is out, then the pressure is okay and you've relieved the tension pneumocephalus. So that is what we normally do. And we see a lot in a lot of trauma cases, not lots, but yes, we do see in a lot of trauma cases, or post pituitary tumor, if there is an ongoing leak and if you do a lumbar drain or a lumbar puncture, that is another situation where you see this kind of tension pneumocephalus. But I think you managed the case very well. And do we have any questions? I see Dr. Ibrahim's hand raised.
A nice lecture, thank you. Nice lecture, and good to understand some problems with young neurosurgeons. Just that, and I would like to say, Professor Baskaya, hello, and I'm glad to be here. But I can say a few words later on this. Let's complete with the first.
Professor Baskaya, would you like to make some comments on this
Yes,
case?
thank you very much. And I am sorry for unable to join you guys right away. I had some difficulty with the link. Yeah, we see sometimes this, and what I teach my residents, when they pull ventriculostomy, if the durotomy is large and the skin incision is big and air, and the patient has a intracranial hypotension, it can suck air inside. So when you are removing, just put your fingers, compress the wound, remove it, and quickly suture it. Or assistant can irrigate during that procedure. When it happens, I think the presenter did very well, and you can do other things too, like you explain, and its case is well managed, and it happens, unfortunately. When you do this kind of beautiful surgeries, sometimes you get complications, and you need to know how to deal with it.
Thank you, Professor Baskaya. Dr. Ben, you want to say something?
Yes, thank you. And there was handling, the drink handling is very good for the residents to learn, and it's very important in our daily practice. I found that, like, I've experienced that when we are closing the galeal layer, so we could inadvertently make some damage or small holes on the UED when we close the layer by the needle tip of the suture needle. So sometimes these may be small and get unmechanized, and you only realize that when there is I mentioned in a case that for example, when the pressure is low, you may get air insucking into the tubing, and or sometimes there would be a CSF leak which you can't find the source, but turn out to be from the damaged UED. So I would advise my my junior to start the closure of the galeal layer, starting from the sign of the wound, which is closer to the exit site, to avoid damage the UED.
Thank you, Dr. Ben. Are there any questions? Other questions? Actually, air in... Yeah, go ahead. Go ahead.
Please go ahead. Please go ahead. Please go ahead.
Sachin, you go ahead.
No, my question is something else, so I don't want to change the context.
Okay. So normally we also see a lot of air, pneumoventricle, when we are doing posterior fossa surgeries, especially fourth ventricular tumors, because we do them in the sitting position. So just having air in the ventricle, even if it is a huge amount, if patient is not clinical symptomatic, don't do anything about it, because that is not a problem. It is only when the air is under pressure, or if the patient is having those kind of symptoms, that's when you need to treat. That is just something that, it's our experience. We see a lot of air, pneumoventricle is not that uncommon. Yes, Sachin.
Yeah. So I wanted to ask one question. First of all, I would request Professor Fawad Firzad, who's also a discussant, to please kindly make comments about Dr. Mishari's presentation. Dr. Fawad.
Hello. Thank you very much, Professor Mishari. Assalamu alaikum. MashaAllah. Ahsan. Thank you for nice presentation. And it's good lesson, best lesson for young neurosurgeons, because our young neurosurgeons, they fear of complications. Every time they face with complication, in the next operation, they have panic and fear that's maybe complicated. And for this reason, if we share our complications and how to deal with complications, how to manage the complication, it's make for our young follower, that's easy to how to deal with complication, and it's good to discuss on complication, how to manage it, and it's very good. And also, I like your advice about prediction and dreaming before the surgery. It was good lesson for, especially for young neurosurgeon and for residents, that prepare for the operations. And nowadays, we advise them to make on virtual surgery or maybe on the model on the to the leg. And also dreaming is also good, and also explaining how to manage the complication and learn lesson from the complication is a great idea. And thank you for sharing. MashaAllah. Awesome.
Thank you very much, Professor. So I wanted to ask one question, and wanted to tell you, I also had one case like this and how I manage, and maybe comments about the expert about that strategy. First of all, my question to you is, right at the beginning of your surgery, you showed one drain, and you're keeping that drain under the patty, and you mentioned that you're keeping that drain to keep the field dry. What was that drain? I didn't get. What is that drain?
That was the Spetzler microcatheter. We do it in all the retrosigmoid or in the lateral position. You keep it lower with the gravity. Once you irrigate, it's just like another hand with a suction. It will keep your feet always dry, because whatever comes from the wound, it will be sucked immediately by this continuous sucking Spetzler microcatheter drain.
Okay. It's designed for, Dr. Spetzler designed it for carotid endarterectomies or bypass surgeries. There are 3 or 5 French sizes, and you keep in the field. It's just spontaneous suction, but its holes are so small it doesn't create a problem for the field. So it's very good way of cleaning the field, surgical field.
Now, let me tell you, I had the same similar cases and how we have managed it. And I'd request your comment and the comment by the other experts. So we went according to the law of the physics. The law of the physics says air is light, air should go up, water should come down. So similarly, we had a case of pan pneumoventricle, and it was tension pneumoventricle. Of course, one EVD was there, but what we decided, we thought we'll put one more EVD from the other side. That side, we're going to bring it down, okay? And we'll put some saline through that side. Now the air, because the air is light, it will go out through the other side. Slowly, over the period of time, by 24 hours, the air had gone out, and from this side, since we had put some saline, the whole pneumoventricle, not completely, but partially it had been recovered. So I don't know whether it is correct or not, but we just thought that, okay, let's go according to the law of the physics. Air is light and water is heavy. So water will come down and air will go. What do you think? What is your comment? Would you still go with your strategy of that particular strategy which you used, or?
Yes, because both of us are using the physics. Once you put the other end of the AVD underwater, just like how you treat tension pneumothorax, that's what then you are replacing the pneumoventricle with your saline. After you decompress, you can irrigate inside very slowly, allowing the air to go out through that AVD under the water, and you will see the bubbles. We have at least 3 cases where we had to take them for to do the same thing over the last 5 years. They all had a very nice post-operative image, and more importantly, the patient improved almost immediately.
That's what is important at the end of the day. Anybody wants to make any comment?
I'd like to say something about that. Physics, like there are different ways of dealing with this. You don't have to take the patient to operating room if it is really emergent. Just keep the patient flat, or even Trendelenburg, and let the drain at the ground level, floor level, drop to the drain. That will get the air in a few minutes. And you can give non-breather 100% oxygen. That will help also.
But Professor, would having the patient Trendelenburg, do you think that air can go into the spinal cavity?
No, it cannot.
Okay.
It will push out. Okay. It will come out because you are creating you are preventing the venous return, increasing the intracranial pressure. That will help to mobilize the air out.
Thank you, Professor. any other comments or any questions from anybody? Or I can see there are a lot of attendees also. If anybody has any question, please just raise your hand. So I can convert it to panelists and you can ask your question.
I think in the Q&A, there are a couple of questions, Sachin.
Yeah, okay. So there is a question by Dr. Temur and Dr. Musa. Dr. Temur is asking, do you use high flow oxygen therapy to remove the nitrogen content from the pneumocephalus? That is one question. You want to answer that question, Mishari, or you want to take both the question?
We would do that, but for a simple pneumocephalus or pneumoventricle, not for patient who has actually tension and high ICP and is deteriorating in front of you. Cannot rely on, this will take time. Putting oxygen will take some time until that air resolved.
Okay, and if high flow oxygen, what is the rate of oxygen and what kind of oxygen, like you put the nasal prong or oxygen mask or?
Breathe 100% oxygen, and we keep it for at least 6 hours.
Okay, okay. There is another question by Dr. Musa. He's asking, as a radiologist, in some cases, when there is no trauma or other sources of air leak, it's important to see the shunt in thin slices in CT with the change in the window level. To see the shunt pin pure sign. I am not getting that. Let me search where is Dr. Musa and I will promote him to panelist. Dr. Musa, just accept my the invitation to promote as a panelist. Yeah, he's there. So please kindly unmute yourself and ask your question, Dr. Musa. Please introduce yourself and where are you from, and please ask your question. You have to unmute yourself and maybe you can start your video also so that we can see. Dr. Musa, are you there? Yeah, we can see you now. Yeah, please go ahead, ask your question.
Yes, thank you for, it's a very interesting topic. I'm a radiologist and I'm reporting sometimes to my colleagues in the surgery department here in Denmark. Sometimes there is no trauma, but you can see there is no more ventricle. And if it's tension, so you have to go and find the sources. As Dr. Ben said before, that we can see it could be a complication of during the suture. But that's very important to see in the change the window level, see through all the line of that shunt or the drain and see if there is any leakage there. It can be air leakage. It can be also water leakage. That it depends on how the patient is in the sitting or probably in the leaning position. But it's very important to change the window level and to find the sources. That's just only a comment. And thank you for giving me the chance, because I have typed my question and there was some kind of autocorrection, and that's why it didn't come through the right way.
Thank you very much, Dr. Musa. May I know where are you from?
I am originally from Afghanistan, and Dr. Fawad Pirzad was my professor there in Kabul Medical University, but I'm working right now as a specialist in neurology, and I'm a radiologist as well.
Thank you for joining the session. Please do join in the future, and thank you for actively participating. Thank you very much. So, does anybody have any other question? If not, then we'll move ahead and we'll go back to our first talk. I would request Dr. Mishari to please be with us, and at the end we may have certain more questions. We can again participate. So, Dr. Ben, can you please introduce our speaker and invite him to for the presentation?
Yes, sure. So our next speaker will be Professor Stafford. And I think without much introduction, I've been following professors in the Stafford lecture for quite a long time, because I admire his inspiration on micro neurosurgery on me. And I saw your lecture on AVM and also the vascular bypasses, and also you have a book on those of those complex surgery for those functional cases. especially the limbic system. And I really like the content of that book. And so without much introduction, I would like to invite Professor Mustafa to start his lecture on the AVM, and I'm really looking forward to it.
I'll start sharing with my screen. Again, thank you very much. Thank you, Professor Kato, and all the organizers, Dr. Shah, Professor Shah, and rest of you guys. And I'm sorry there was some link issue, but I also watched the first presentation, wonderful case presentation, and complications are a part of the daily neurosurgery. So the Ben asked me to talk about surgical and non-surgical treatment modalities for intracranial AVMs, and how we decide when we need to do something, or sometimes doing nothing is a good option as well. So this is my conflict of interest, and this is our lovely City Medicine. So what are the main? So I'm not going to talk about the natural history, you know, the numbers, the annual hemorrhage rates. You guys know all that, and you can easily read and learn for the young colleagues. But I'll try to give my perspectives in AVM, and I train with Roberto Hiros, you know, the father of the intracranial arteriovenous malformations. So some of them, this is his reflections, his legacy. So sometimes just observation might be a good option, and especially the large, very complex diffuse AVMs. If you can treat, microsurgery provides you to chance to cure the AVM. Radiosurgery is effective in small and deep locations, and sometimes we embolize to make the AVM amenable to the radiosurgery. And sometimes embolization can be just solely a treatment modality and can cure the AVM. Or in very complex AVMs, you can combine these modalities, multi-modality approach, and make the AVM amenable to do a microsurgical resection. And now, today I'm going to talk which AVMs to operate, which AVMs not to operate, when to operate, how to operate, and when the AVM is associated with the pedicle aneurysm and is source of the hemorrhage, what to do with that aneurysm, or there's an aneurysm, but there's no hemorrhage, what to do with that aneurysm, and should we embolize or not embolize the AVMs preoperatively. So I'll go one by one. First, I'll start with which AVMs to operate. So when we make decision in the when to operate, you know, this age is very important, right? The age determines basically the natural history of the AVM and patient's general health, neurological status, when recent history of the hemorrhage, and what kind of symptoms the patient having, and patient's occupation and hobbies, right? If you have a singer and that patient is making living by singing, you don't want to operate in the Broca area AVM because that may give patient to a lifetime disability. And patient psychological makeup, is patient nervous about this AVM, or patient is nervous about consequences of the treatment of the AVM. So, and of course, there are other physiological factors, right? Location, size. So we pay attention to this configuration, compact versus diffuse, and location and the pattern of the arterial supply, deep perforators, and venous drainage, outflow obstruction of the venous drainage, associated aneurysm, blood flow, evidence of still, and the recent hemorrhage or fresh hemorrhage. And again, this another important factor is the neurosurgeon herself or himself. Does neurosurgeon have experience is there other modalities available in that institution? And is that neurosurgeon familiar with her or his morbidity for each treatment or modality? Is there other supporting facilities like neuro-ICU, neuroanesthesia, intraoperative angiography? And is there an experienced surgical assistant who can assist and help during these long hours of surgery? So as you guys know from my presentation, I don't like talking about too much data. I like to go to the point and show you cases that why I choose the treatment. So this is a 60-year-old man with the personality changes, and when you discuss with him, he's on the actually he got the diagnosis of psychosis, and he's been on the psychotic medications for so many years. But he's very active. He's working. But he's dependent on these medications. He says that I'm not functioning well if I'm off the medications. And some psychiatrist eventually orders a MRI and found this, is the anterior cingulate medial frontal AVM, and it's very high flow. If you look at the dynamic images of the this AVM, it's very high flow. And it might be causing the still, and that maybe that's why he's not feeling all right all the time, because he's encephalopathic from the still. So I discussed with him this treatment options, surgery alone, or embolizing some of the feeding pedicles and doing the surgery. But radiosurgery won't cure this AVM. We know that. This is sizable, high flow AVM, and radiosurgery will have problem. It's just, I don't want to go to the details. When you apply the basic principles of the microneurosurgery and go one by one, find the feeding arteries, find the draining veins, and isolate the AVM, then you'll remove this. And I'll show more videos in the other AVMs. So I'll skip this. And this is the end result. MRS outcome score is 0. And believe or not, it took 6 months, but he's off to his psychotic medications, and he lives normal life without any medications now. So that's the case. It looks simple. Doesn't look like it's symptomatic, but you help the patient. Also, you are curing an AVM at 60-year-old healthy person who has another 20, 30 years to live, right? You are not subjecting him to do chronic treatments like partial embolization and partial treatment, inefficient treatments like radiosurgery. I'm not saying radiosurgery in general is inefficient treatment, but for these AVMs, it won't cure this AVM. So this is a nice, simple AVM, right? So now we got to the smaller AVM, but in a more complex, more difficult location. And as you see, it's right next to the receptive speech. It's quite adjacent, and patient is very nervous about this AVM. And people told him that, this is not, a small AVM is not going to bleed. There's no such a thing. Size doesn't matter in the arteriovenous malformations. And this patient is also healthy, doesn't have other health issues, and in long life expectancy. So you gather your all preoperative imaging and do the best for the patient. So again, it's not very low flow AVM, large, and it's not super high grade, but you have to come out from the surgery with the 0 morbidity. The only potential morbidity here is the speech, receptive speech, but follow the principles set by our pioneers, right? Find the AVM, define the normal anatomy first, always in any AVM, and then define the pathological anatomy of that particular AVM. And what is the pathological anatomy? Feeding arteries, draining veins, and And some of these feeding arteries can be directly feeding the AVM or passing by and giving side feeders. So don't take any feeders too early in the dissection of the AVM. So you identify them, making sure they're going to do AVM and then take. So you see, this artery, for example, is an en passant artery. It's passing by and giving side feeders, and you isolate those side feeders one by one. So if you follow these and do the other adjuncts, ICG green, intraoperative angiography, monitoring, not monitoring, whatever you need to do, but at the end, you are doing the surgery, okay? So you are doing the surgery, and it's not ICG green doing the surgery, not intraoperative angiography suite or monitoring. It is you. See, I isolate another side feeders and giving these small branches, and keep going, and you remove, isolate the AVM, and eventually you'll remove it. Okay. So, and believe or not, it's right adjacent to the speech center, but he woke up perfectly fine and remained fine. But unfortunately, he had a wound infection. We had to go and clean, but it didn't cause any long-term or short-term morbidity. This is the two patients I had in my AVM series who had the wound infection. And unfortunately, that's nothing we can do about it. You do your best to avoid, but sometimes it happens. But again, perfect outcome. He's cured. Grade 2, an eloquent brain, but can be done. This is again the patient presented with seizures. So this is deeper AVM. The first two AVMs, although the other one is interhemispheric, it again is easier to reach than this AVM, right? This is a young woman, again, presenting with the seizures, and it's hippocampal AVM. To me, it doesn't matter is dominant site or non-dominant site, any hippocampal pathology is a high-grade, complex eloquent relocation. So you need to know how to get there. There are many ways of getting transsylvian, subtemporal, transcollateral sulcus. So, but it is not easy AVM. The reason is deep drainage, but most importantly, very fine feeding arteries from the anterior choroidal and the PCA. So incision is as usual, craniotomy, you go. So I went through the transcollateral sulcus. To me, subtemporal is not good enough in these cases, and you cause more damage. And you find the AVM, you go to the ventricle, you find the pedicles, and you see in the ventricle, we are there. And locate the AVM. See, I'm using every modality. I know where it is, but I want to confirm. I want to have the full understanding of the pathological anatomy, first normal anatomy, then pathological anatomy. See these fine feeders, and you go isolate them. So like you are doing amygdala hippocampectomy, basically you are removing the AVM. So it's good results. She's seizure-free and good anatomical and clinical result. So now this is a higher grade 3 AVM. Is completely asymptomatic patient, but young, super nervous about this AVM, is in the dominant hemisphere as paracerebellar and temporal. And they recommended all kind of preoperative embolization and other things, but be careful in these paracerebellar AVMs because many of these MCA branches are en passant arteries. So when you are embolizing, you can cause stroke because you don't know actually when you are inside the aneurysm, you can do super selective or everything, but you may not be able to tell all the time what kind of feeding artery. Is it direct feeder or en passant artery? So this shows the location of the AVM and the brain slice. And you see the small micro clips we use, disconnected this en passant artery, remove it, perfect outcome. Because I am working around the AVM. It is different from the glioma surgery or other surgeries we do. You don't damage the cortex, okay? And there's a good plane you can provide with your micro dissection. So then, which AVMs not to operate? Right? And now we saw all grades I operate, grade 4, grade 5, but not every grade 4 or grade 5s, and very small number of grade 3s. Those are especially if they are located in the brainstem or thalamus or basal ganglia. Grade 3 AVMs, rarely, those locations I rarely operate. But I learned from one thing from Dr. Hiros, no algorithms. If you say I operate only grade this, people will misunderstand that, okay? And most of the grade 5s nowadays, we don't operate, and very selected, very selected grade 5s we operate, and some, again, selected grade 4s, and a very small number of grade 3s, I will not do surgery unless there's a very specific reason. And also incidentally found AVMs in elderly patients with short life expectancy or very significant medical morbidity. You need to be careful operating on these patients. You don't want to cause problems and accelerate their pre-existing medical problems. So as you see, I'm not showing any case on the because it's very clear, like diffuse hemispheric AVMs, grade 5, grade 6, or some grade 4s with the high morbidity chance, I will not do surgery. Then the next question, when to operate, right? If patient comes asymptomatic, electively you can do surgery anytime. Some of these patients will come present with the hemorrhagic episodes. So for example, this patient almost every year presented with some kind of hemorrhage, and they call this AVM inoperable. And this is not, hemorrhage is causing life-threatening problems. So you can wait and electively do these surgeries or semi-electively after the acute phase of the bleeding goes away. So, and this is what we did, because hemorrhage is just giving him a headache, no other symptoms. And we studied this AVM and study the AVM, how close to the motor cortex. You see here is just, this is cingulate AVM, but under the motor cortex. So this is all, see, and this is one of the earlier cases in here in medicine. I embolized. It was a mistake. I didn't need to embolize, but I took the risk of the embolization unnecessarily. But I thought the deeper part, PCA perforators will help me. And here is the embolization material. At surgery, in reality, it wasn't helpful at all. So I found all those embolized vessels, and this is an old video. The quality is not good. I apologize for that. See, this is all ACA feeders, and I'm isolating them. Then why I am taking the risk of embolization? So I'm going to touch base on this later. But this is a grade 4 AVM. It's quite sizable and deep drainage, and is in the right adjacent to the motor cortex. Thus, is he going to get the motor deficit? He may get motor deficits, but as long as you don't damage motor cortex, he'll be fine. He will improve. And first 2 days, maybe 24 hours to 48 hours, he had a lower extremity weakness. It was just mild weakness, and it got completely better over time. And he has been living normal life since then. He's cured. So this is the different case now. This is different than the first case, right? There is hemorrhagic presentation and is known AVM in 55-year-old male patient, and presented with the coma, unconsciousness. And he was followed with this AVM because of seizures, and family, everybody knew it's not in our center. And he was transferred to our center. And he had this AVM, these CT angiograms from the outside. sorry, no, these are the new, but he had the CT angiograms exactly this location. No change in the AVM, no associated aneurysm, but he's GCS3. What are you going to do? So, of course, like tension pneumocephalus, you'll put the ventriculostomies, right? 1, 2, stops working, is not improving, stops working, not improving. So what? He's gonna die. And so I took him surgery emergently, and I very aggressive surgery. You have to have the capabilities of doing it. I did the large opening, so this is superior frontal gyrus. I directly went to the ventricle. I need to clean that blood to create a path for ventriculostomy to work. So I'm in the ventricle, right? Like doing endoscopic, but I'm doing open surgery because I'm going to deal with the AVM in the same time. I'm not going to subject him to the 2 surgeries. I already did the surgery. I need to do decompressive craniectomy. Under direct vision, I am putting the ventriculostomy catheter. Okay, then I go to the AVM. Okay, now we stabilize him. And like I showed you guys, defining the normal anatomy, defining the pathological anatomy, and removing it. Here, you go all the way. This is a fusiform gyrus AVM going into the paracampal gyrus. So I'm in the lateral ventricle now, temple horn, cleaning the blood from there. So my philosophy in this, if you do something, you should do all to give the patient the best chance, okay? And don't be afraid of doing these surgeries. I mean, we did in the past. You do whatever, it's open, endoscopic, but in this case, there's no point. I already made the opening, the big decompressive craniectomy, right? So going to ventricle, isolating the AVM, going to the ventricle from the temple horn, and cleaning. And this is immediate. See, we created, so like, this is pneumocephalus, but not tension pneumocephalus. So this is in almost 3 weeks, and this is in 2 months. It's mildly hemiparetic maybe here, but good outcome, and he's cured. But this is the case, not very often you do. You do only if this is necessary, because AVMs, some complex AVMs, can be difficult to deal with in the emergency situations. So you want to have, like the first case, you want to have the rested brain, relaxed brain. But in this case, we didn't have option, and he was right there. And an AVM didn't take too much to remove it. And then the most important, right? We are neurosurgeons, and we want to promote microneurosurgery. So how to operate the AVMs? I just show short videos, but I'm going to show one case. And that in that case, is usually the videos you see is much better in the surface AVMs and not very large AVMs. The anatomy is not disturbed. The field is not very red, so the participants can see. So basic principles, right? Find, coagulate, divide arterial feeders. Dissect the needles of the IVM circumferentially. Do your dissection best before you start taking any feeding arteries and disturbing the venous outflow of the AVM. And then lastly, divide the main drainage vein or veins one by one. So we know that it's very important to maintain the venous drainage of the AVM until last moment, because if you disturb it, it's going to cause congestion and bleeding, and eventually you are running into the trouble. And when you are doing this, you are minimizing the trauma to the surrounding brain. So this is my thing, okay? When you do any craniotomy for AVM, just don't be minimalistic, please. Just do largest possible, use your navigation, and when you open everything, it should be under your direct view, draining veins, arterial feeders, any anatomical structure that can provide you a landmark. Inspect gyral and sulcal anatomy, and then compare location of feeding arteries and draining veins with your angiogram. So correlate how they look, how they were looking in the angiogram. Are you missing anything? And your imaging should be available. Constantly look back and forth, and be aware of in large, gigantic AVMs. Be aware of transosseous feeders. These, when you are doing craniotomy, if your young colleagues are opening for you, just warn them. You know, when you do this kind of surgeries, you can, when you elevate the bone, you can have excessive bleeding, and then you already lost 2 liters. And just enough dural opening, not too much, not too little. And when you are reflecting the dura, opening the dura, be extremely careful. If possible, open the dura under the microscope. And some of these draining veins or feeding arteries might be very stuck to the dura. So dissect them. If you cannot dissect, at least cut around them and leave piece of dura on these structures. And again, I'll continue. I'll touch base on this when I show the video, but and so another thing is this in Yashagi's style, with continuous circumferential dissection in a spiraling fashion. Bipolar coagulate arteries, veins gradually in few millimeter length, not just in one short. You coagulate like this. If it is short, you cut it, it starts bleeding and you cannot control, or it starts sticking to your bipolar tip. And if possible, is irrigating bipolars, or your assistant is continuously, experienced assistant continuously, slowly irrigating when you are coagulating. And if you encounter bleeding from the AVM, don't try to coagulate. You can cause more bleeding. Just put Surgicel gel foam, cotton pedis, and gentle pressure. If you have a retractor, retract the AVM with the retractor. So then you're causing some kind of compression. And if AVM bleeding is not from the AVM side, if bleeding from your brain side, that's the most dangerous one. Don't try to pack those. If you pack it, it's going to be intraparenchymal hemorrhage or intraventricular hemorrhage, and suddenly you start having the swollen brain. And now I'm going to show you, this is a straightforward case, so then you can see the anatomy better, and then the position, everything should be perfect. And then see, we open the dura, but you see there's stuck. I know that. And that's why I'm doing it under the microscope, okay? And eventually I'm gonna do this dissection anyway. So just stay on the dura side. Don't go too close to this vascular structure, which is in this case a draining vein, and cut little dura if necessary, but stay away and free it, because you need to see the anatomy, right? So then I'm defining the anatomy now. I'm defining first, opening the south side and identifying the gyruses, identifying the potential feeding arteries. And these microsurgical techniques you use, sharp dissection with scissors or diamond knives or arachnoid knives, spreading motions or peeling motions. And your suction hand is the most important hand. You should be able to control your suction yourself, not the operating room nurse or anybody else. And that's why you have to have this graded graded suction tips, so you can adjust your suction severity with your thumb, and you do that with subconsciously. See, I haven't taken any artery. I keep dissecting. That also helps you to relax the brain, because you are dissecting the south side, you are suctioning the CSF, okay? And keep changing your planes, okay? Just go around it and isolate this AVM completely. Once you define the normal anatomy, define the pathological anatomy. That is the draining veins and feeding arteries, okay? And you can do these techniques, okay? You can learn when to pull, how much to pull, how much to cut, how close to cut, and go to the lab for that, okay? There's a reason we go to the lab all the time. You learn this when you're peeling the cadaveric arachnoid, P arachnoid. You are cleaning the P arachnoid of the cadaveric brain. You are doing these practices. And this is microjewelers. I am pulling tension. If you apply tension, you can cut the arachnoid much better, okay? If you don't apply tension, you won't be able to cut. And when you are trying to cut, you can cut the injured artery. Okay, it takes time. And what could I have done? Some people will do buzz, 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 go to the subpeel, and without defining it, almost like doing lobectomy or metastatic tumor or meningioma surgery. AVM surgery, like Dr. Atul Goel says, is the last resort, okay, last highest level. So don't do that kind of surgeries. And no, Atul also says classification, like we are so stuck with these numbers, grade 1, grade 2, grade 3. He says that there's a simple AVM, I can operate, there's a moderate difficult AVM, difficult AVM, and impossible AVM. So can we operate all these AVMs? Yes, but we don't want to cause trouble, right? We want to help the patient. So this is not difficult AVM. The reason I am showing you, you can see is, it's on the surface. So then I'm defining this. See, this is a thrombosed vein. So, and believe or not, in some of these AVMs, you will see hemosiderin staining. Even though we thought AVM didn't bleed, there are microhemorrhages or old hemorrhage. See, that is a thrombosed draining vein. It's spontaneously thrombosed. So I don't want to take too much time, but this is just to show you the basic principle of it. And then once you start doing this, and when you identify the feeding arteries, and then make sure where they are going. So I don't know if this artery is going to do AVM or passing by and giving site feeders. So it takes a couple of hours to get here. So then if you are not sure that artery is going to AVM or not, just put temporary clips that will reduce the pressure on the AVM nidus, and you can do safer dissection and go do something else, come back to that region. So now you see that AVM is turning to blue. That means, see here, you are doing good. So that means your strategy is working and you are making progress, okay? So you go, continue taking that. Now we are sure, replace that temporary clips with the permanent clips. And now it's time to go subpeel dissection, or Ernest name calls it dirty coagulation, right? You just go, but before you start doing the dirty coagulation, you do clean dissection, okay? That's the key in this. Go around it. AVM is turning more blue. You are making progress. So there are vessel loops, AVM loops, okay? You keep those loops inside your dissection plane, not outside. So if you encounter the bleeding from those, just be careful though they don't retract and go into the brain parenchyma and cause interparenchymal or interventricular hemorrhage. So I'm keeping those loops inside. Then I'm retracting the AVM, not to the normal brain. And these are draining veins going towards the labbe, and you're gonna isolate. Be patient. This is the sacred time. So this is another deep feeder. I'm not sure that's going to do AVM directly or giving site feeders. So I'm inspect first, dissect again. So this is the last piece of the AVM. Only take the ones that going to the nidus directly. If there's a site feeder, take those. Okay. And it's going to be the last piece, and we'll remove it. And then the last, see the vein turned blue, you cut, you remove it, done with it. See, this artery actually was en passant artery giving these small side feeders. Perfect outcome, cured, and this is the case example. And then people talk about these aneurysm, perinidal. These are AVM vessels. Defining them as a nidal aneurysm, internidal, perinidal doesn't make sense. Aneurysms in the pedicles make sense. Okay, and this is also, there's a situations and the locations you cannot just go around and remove these AVMs, right? The brainstem, thalamus, basal ganglia, and ventricular surface, small AVMs. and you don't want to be too much, you do too much intraparenchymal dissection. This is the case example, presented with the thalamic hemorrhage. It's as patient is not hypertensive. I told residents to get the CTA. CTA shows the AVM, and then we do the initial angiography. It shows a thalamic AVM on the thalamus surface, and this is the MRI. A couple of months after. Initially, she was in coma, hemiplegic. She improved, and now we have repeat the angiogram again, because sometimes in the bleeding conditions, the angiogram might be disturbed. If you want to do a elective surgery, repeat it again to see the last current anatomy of the AVM in the angiogram. And this is the dynamic angiogram. And now we talk about doing radiosurgery versus surgery. The patient had a previous radiation for her other cancer, and it's cured. And she's very scared of radiation. She didn't have a good time when she had the radiation first time. So she said, no, I don't want anything. Either I'll just watch this, I'll die from it again if it bleeds, or do surgery. So do surgery, how? We call it in situ occlusion. Go to the AVM just to show the surgical technique and supracerebellar approach, and opening the arachnoid, finding this AVM on the surface, and again getting the initial ICG. You can do it, you don't have to do it all the time. And small arteries going to AVM, I am taking them, occluding them with the micro AVM clips, and see any changes in the MEPs, SSCPs. No changes. I coagulate and cut them. But after doing this multiple times, and look at this vein turns blue, but the main vein, this is the draining vein, is not turning blue. So that means whatever I do is just partially helpful. So I need to be more definitive, right? I want this vein to turn blue, not only one. So I'm isolating those feeders, cutting, coagulating the surface, and encountering little bleeding, see, and these irrigating bipolars are helpful, but again, their tips are very big. So now I'm in the previous hemorrhage cavity. I'm looking more feeders, and so I can coagulate and make this vein blue. So there's one potential there. Again, we are doing it, still filling, see, right away. This is the early draining vein, and now I got in the bleeding. That's the main feeder, okay? That's the previous hemorrhage cavity. So if I stop this bleeding, this AVM vein should turn blue, okay? It's getting more bleeding. Be patient, don't panic. And then go slowly. See, it's still bleeding, but it's under control. It's not like profuse bleeding causing problems. And once it stops, just gentle. So the suction here, just suctioning enough blood, okay? So now these are very resistant to coagulation, okay? That's why you coagulate in multiple points and don't break when you're coagulating. Use irrigation. See, now is AVM vein is gone. Okay, once that turned blue white, that means AVM is gone. What we did, we just coagulated the AVM vessels, coagulated after turning the blue, coagulated the main draining vein, and got to this point. So what to do with the associated feeding pedicle aneurysm? which is the source of hemorrhage. Okay, so that's another common question I get from the young colleagues. So this is an AVM, cerebellar AVM, feeding by this pica, and there's a pica, distal pica aneurysm, and patient presented with the hemorrhage from this aneurysm, not from the AVM. Okay, so when you can treat the aneurysm and treat the AVM in the same sitting or separately, depends on the patient's condition, and because that's the source of the AVM. Another question is, can you treat these aneurysms endovascular? Yes, of course you can, but if I'm going to do surgery anyway, I can clip this, and coiling these distal picas are not easy, and you can lose the vessel, or sometimes they take the vessel after the choroidal point, and you don't want to do this, and you treat the AVM, I mean aneurysm. Here you see, and it is aneurysm is gone now. You remove the AVM, and you are cured. And this was a Hunt and Hess grade 2, and this is a recent case. So first we treated the aneurysm, then the AVM, and done with it. Okay. So this is a different case. It's a complex AVM, and there are multiple feeding arteries and the PCA and the distal MCA. So I'm going to speed up a little bit. Look at these aneurysm. And this is patient is not presenting with the acute hemorrhage, okay? Patients presenting almost asymptomatically increasing headaches. So if you treat the AVM in these cases, look at this is pre-op, this is 6 months later. Aneurysm is regressing. If it is not regressing, then treat at that time. But don't jump and do coiling or something or clipping this and then try to do this, because if you remove the source, this artery doesn't need to push blood more. Okay, just treat it, wait and see. And in my experience, most of the time these pedicle aneurysms that did not bleed they're going to regress over time. And in 6 months we'll do another angiogram. I am 100% sure this aneurysm will be even smaller. Look how bulbous aneurysm, in 6 months it regressed. Okay, this happens, is described. Just be careful, carefully observe. And last question, embolize or not to embolize the AVMs perioperatively. So why do we embolize AVMs? It either to cure the AVMs or preoperatively as an adjunct or pre-radio surgery or palliative, okay? And this is what I was doing before, elimination of proximal ruptured aneurysm. If I can clip the aneurysm and treat the AVM sometime, why am I doing it? Obliteration of deep accessible arterial feeders during early exposure. Can obliterate these during early or late exposure anyway. So why am I embolizing this performing high risk embolization? Stage reduction IV shunting. No need for in many of the AVMs, and yes, in some 4s and 5s, if you intend to cure, you may have to. Reduction of blood flow to AVM makes surgery easier. This is definitely not. It doesn't make surgery easier. And reduction of blood flow to make surgery safer, as is technically endovascular, not easy. You are doing still same dissection, either you embolize or not embolize. And this is the case I showed earlier. This is the case I'd use the faulty judgment and embolize AV shunt, and it didn't help me at all. Plus, right after embolization, patient starts having more symptoms. We see the draining vein is thrombosing. So now is the elective surgery becomes an emergent surgery, and we remove this AVM, but I'm removing it urgently, emergently. So it wasn't necessary. I could have taken that shunt at surgery. I don't know. So you grew up with these things, and then you say, okay, let's do this, and then you end up having more problem. And correct judgment, no use of pre-op embolization. Look at this young person. This AVM is called inoperable, multiple centers, and then we do surgery. Perfect outcome. What am I going to embolize here? All these branches are directly going into the AVM, and I'm going to embolize, and then I'm going to remove. I'm going to get those feeders anyway. So I'm leaving a dura on the, look at this dura on the feeding artery. And do the same dissection anyway. And I'm going to put the clip again, coagulate and cut those feeding arteries, embolize with onyx. So I'm doing the same dissection, and at the same time, I'm taking the risk of embolization. Embolization is not risk-free procedure. But these are all numbers from the literature. Okay. So if you can, just do not embolize. Yes, if high flow AVM, you want to reduce the AVM pressure and then do the surgery, do that. And as I show you, sometimes embolization turns AVM surgery from elective to the urgent or emergent. And this is my mentor says, overall treatment risk morbidity for a particular patient will be lowered by performing both embolization and surgery rather than surgery alone. If it is not lowering the morbidity, don't do it. And nowadays, I don't do any embolization in most of the grade 3s, none of the grade 1 or 2s, okay? And surgical outcomes all depends on the multimodality approach, proper surgical planning, intraoperative guidance, detailed anatomical knowledge, rigorous training. And this is what our pioneers did it, right? So you grade 1, 2s, you should have zero morbidity, zero mortality. And these are the problems I experience in faulty judgment operating in some grade 5s and grade 4s, and most of the time we don't need to. Abuse of embolization, lack of embolization, incorrect conceptualization of the AVM, underestimation of the patient's comorbidities, inappropriate surgical planning, and wrong surgical timing. So don't follow the algorithms, don't follow the guidelines. That particular patient is very different from the textbooks on the papers you read. Okay, and these are the causes of the intraoperative problems. Okay, too wide margin of resection, parenchymal hemorrhage, unrecognized intraventricular hemorrhage, early occlusion of the venous drainage is very common. Some of these venous drainage you don't see in the angiograms, and you think, oh, it's okay, I'm like doing the dirty coagulation or coagulation, poop, AVM starts swelling. That means that you are interrupting the venous outflow too early. And these are all defined, and this is my take-home message for you guys. Grade 5 and some grade 4 AVMs should generally be treated conservatively. Preoperative embolization should be used judiciously, only reduce the risk of overall treatment plan. And indications for curative or palliative or pre-radiosurgery embolization are very limited. Radiosurgery has role in AVM treatment, but only small AVMs with unacceptable surgical risks. And always, you know, this like I told this million times, don't follow any algorithms, to present the best option to the patient, okay, and the family. Go to the lab, study in the lab, do these dissections in the cadaveric brains or small animals, and learn these techniques. Watch your masters, listen your masters, go dissect in the lab, and then go do it in the operating room. So thank you very much. I took so much time, and I apologize for the delay. I stopped sharing my screen.
Okay, thank you, Professor Mustafa, for your inspirational lecture again. So as a young neurosurgeon, I find your AVM is very difficult to manage to start with without training. And I find your tips especially concerning those microsurgical techniques is very useful. Also, I would also like to thank for your dedication to teaching young neurosurgeons also in other lectures, for example, translab, or for example, the Gaume bypass. I've really learned a lot from it personally. I would like to thank you for your teaching. So maybe shall I open the floor for the discussion from the panelists? Professor Hida, you want to add some comments?
Yeah, I think Professor Baskia, that was a wonderful presentation as always, with beautiful technique and wonderful cases. And I think you've covered all the aspects of AVM, some controversial things about embolization and about radiosurgery, especially when to operate an AVM and not to operate an AVM. You talked about Professor Goel's classification. It's a dynamic classification and it differs from surgeon to surgeon. And as you grow in your experience, your own classification will improve, in the sense if you're not operating one particular AVM at this time, maybe 2-3 years down the line, you will feel confident to operate this AVM. And it is certainly the last chapter in AVM surgery. There are a few things that I would just like to ask you. Sometimes we use 3D models for studying the AVMs. Have you had any experience with this?
No, I didn't pursue on that. I could have, but in some of the AVMs, I don't even look at the angiogram. I look at the MRI. I know where the feeders are. I know, you conceptualize the anatomy. Anatomy defines anything, but for the beginners and the complex AVM cases, do anything you can. And like Atul says, sometimes, like you said too, the cases you haven't operated in the past, you start operating, or other way around. The cases you did, you learn from your own mistakes, you stop doing those cases, like some grade 5s, right? So it is very helpful. I'm not against using any technology, but don't rely on that only. Rely on your anatomy, rely on your techniques, and then defining that anatomy during the surgery. That's the key.
Yeah, of course, anatomy is always the key, but sometimes for younger people, this helps. Basically, it also helps. Yeah, it helps you to get how much ever information you want, because it helps in you getting that 3D visualization. Sometimes it helps your mind to create the 3D model in your mind.
You have to have a clear understanding before you go, and when you are young, your inexperience is very difficult. So do everything to help you during the surgery. Do the things before surgery, do the things during the surgery, like monitorization, all that stuff, ICG green, introp angio, anything that will help you and help the patient. So that will save and make the surgery safer. No question.
Yeah. So do we have any questions from the moderators and the panelists? Dr. Fawad? Professor Kato, why don't you start with the...
Okay. Thank you, Baskaya. Thank you very much for your nice lectures. And thank you very much for introducing the Dr. Andrea. She is really nice. Thank you very much.
Thank you. Thank you. Thank you for having me, Professor Kato.
Thanks.
And thank you for your continuous support for the global neurosurgery. It's well appreciated.
Yeah, thanks a lot. So just I want to ask, do you have some experience the resection of the nidus after radiosurgery? You mentioned already in your lectures.
Correct.
So
yes, I haven't done such a case, and I am waiting for a case because it takes 2-3 years to get that AVM part completed. So I have a large case, and the motor, almost like grade 4 patient, had multiple bleeding episodes. So I asked part of the AVM radiosurgerized right next to the motor strip. It's super complex AVM. So she's almost 1.5 years out, and if that part of the AVM is gone, I'm going to operate. But I haven't done it, and limited experience. I think in Stanford, Gary Steinberg has, and Mike Lawton has some cases. But again, it's not like 100, 200 cases that you can talk about the experience, in my opinion. It's just limited anecdotal experience.
So another question is, can you tell us the tips how you can coagulate at the very last stage of the AVM surgery? Maybe it happens as a hyperebic state.
Yeah. taking the feeders are easy. I told, just do a couple of millimeter coagulation cut, but the coagulating that deep feeders, they call it red devils, at the very end of the surgery, hyperemic state, is the lower I like to be pressure low in those cases. And then your suction is very important. When you are suctioning, you shouldn't keep sucking, and then that tiny vessel keeps retracting back away from you. So just stay with your suction and irrigation and continuous coagulation, and count 1, 2, 3, at least 3 seconds coagulation. And don't do this. Dr. Hiros used to call this Mickey Mouse coagulation. Don't do this. It's gonna tear every time. Just stay 1, 2, 3, 4, whatever, 3 seconds at least, and continuous irrigation. Make sure your bipolar is not sticking. And then if it is retracting, don't be insisting. And if you can throw small AVM clips like sound clips, 3 millimeter, 4 millimeter, 5 millimeter, and try to catch that small perforator with the clip instead of coagulating. That's another tip I learned from the Roberto Hiros. Bipolar coagulation, there's a reason you are asking this question, because you have experience and beautiful surgical techniques on this. So don't do dirty coagulation, do a clean coagulation.
Okay, thanks so much. So maybe 1 or 2 questions for you. I think another one is, how do you treat of the eloquent AVM? Only for the radiosurgery, or do you sometimes do the surgery? Or
I do surgery, like I showed in it's AVMs are different from the gliomas. You are not going to do very wide dissection. You are staying right next to the AVM. As long as you don't damage the normal parenchyma and you don't take the arteries going to the normal cortex or white matter, you'll be okay. Patients may have a transient deficits, but they will get better. And that there's always remodeling in these AVMs. And then functional MRI is not 100%. So just don't rely on the functional MRI too much. Functional MRI to get idea where that particular function is or might be, but then you don't just trust that and then go do very wide dissection like a lobectomy. So if you do that, I think you can operate any AVM located in this near speech, and they're not going to be in the speech center, and the speech is 360 surrounding the AVM or 360 motor function surrounding the AVM. It's going to be part of it adjacent to the AVM. You just be careful in that part.
So that question is the diffuse type of the AVM. So do you do the stage, the radiosurgery, or just observation?
Diffuse type of like grade 5s, grade 4s, I will not do anything. Because so palliative treatment, we know that from the literature, is more harmful than the no treatment. Palliative treatment changes the dynamics of the AVM. Palliative surgery, like subtotal resection, subtotal radiosurgery, subtotal embolization, anything you do, you are not intending to cure, is going to harm the patient because it changes the dynamics. And the literature actually demonstrated that there's more bleeding after palliative or subtotal treatment. Palliative treatment only in desperate cases that you have to do something like prevent a still phenomenon or super bad headaches in the extradural feeders. You take those, but don't go try to dissect nidus or do radiosurgery or embolize part of it.
Thank you very, very much for very
Thank you very much.
Thank you so much.
You're welcome.
Ben?
Yes, and I would like to ask a question about the postoperative blood pressure management following the AVM resection. So because different AVM is different, so in your opinion, how would you how would you manage your blood pressure after surgery, and how many days do you think is safe to loosen your blood pressure criteria?
A very good question, man. You know, I like to, it's high flow AVMs, high grade AVMs. I'm very strict about the blood pressure. 9 to the 110, 110 millimeter mercury systolic blood pressure parameter all the time, first 3-4 days. Then every day I increase that 9 to the 120, 9 to the 130. Straightforward case. A small AVM, it's not high flow. And I'll go easier on that, like a couple of days, 9 to the 110 or 120, then go and at least 5-6 days. Super high flow complex AVMs. I sometimes even put them in pentobarb, and then don't wake them up, like Mike in Sydney, Australia, he did it. Just come down slowly and do imaging, make sure there's no hyperemia, there's no perfusion breakthrough, and then wake them up slowly over a week time. That's rare, but sometimes you have to do. The blood pressure management is the most important management in the AVMs.
Thank you so much. So thank you so much. I see Dr. Liu has raised up your hands. You wanted to add some comments?
Thanks, Professor, for a very nice presentation, very educative. I want to ask Prof, when do you use dexamethasone, anti-epileptic drugs, or beta blocker in your cases? How you decide which needed those drugs? And my second question, Prof, in a ruptured AVM, and you decided to do an elective surgery, how long do you wait? Does the residual clot do any advantages for you in your surgery? Thank you, Professor.
Correct. Very good questions. Anti-epileptic medications, yes, for 2 months. If patient didn't present with the seizures, if they present with seizures longer, and I get the seizure neurologist involved, and the dexamethasone, just few days they feel better. The dexamethasone steroids blunts the effect of anesthesia, right? Less nausea, vomiting, they feel less sick. Just few days, different from the brain tumors. They're different pathology. And regarding to when to operate, I like to wait at least 2-3 weeks to get the hematoma liquefied, so creates a space for you, and same time is not hard to suctioning. If you wait too long, hematoma gets fibrotic, and it creates a more problems in dissecting the AVMs. So just that at least 2-3 weeks, and after that it starts becoming fluidy, liquefied, and then you can have much better exposure, and then you just suction that liquid hematoma.
How about beta blocker, Professor, before surgery?
Beta blocker, I don't use for any particular reason.
Thank you, Professor.
Thank you.
Okay, and also Professor Ibrahim, you raised up your hand, and can you share your comments?
Yes, thank you. Professor Bashkaya, good to see you again. Nice video as always. Nice presentation. Thank you. And also thank you, Professor Kato, to give us a chance to listen. Professor Bashkaya, you show us the nice surgeries, great jobs, and so. But for the beginner, for example, because it's this young neurosurgeons panel, of course, when we have some kind of not so big bleeding from the AVM, so this hematoma, it's not removing during the night or the next 1 or 2 days. Usually, I know you say don't follow the recommendation, however, usually we recommend to young guys to wait for 2 or 3 weeks to give the time to angry brain to calm down a little bit, and then we have it's much easier to remove the AVM, for example, grade 1, grade 2, which is recommended for the young guys. What do you think about that? Is it too much to waiting 3 weeks?
No, it is not too much. So complex AVMs, and it's not truly emergency, you don't have to decompress the hematoma. You just wait 2 to 3 weeks to brain become more relaxed and calmer. And then if it is emergency, you decompress the hematoma. AVM is too complex. Stay away from the AVM. Just remove most of the hematoma or do the compressive craniectomy and wait 2 to 3 weeks until patient declares himself or herself or gets better. Small AVM, big hematoma, you have to decompress, then you remove the AVM too. You are right there. And it's not complex. You are not gonna add like 6 hours to the surgery. It's 8 hours. Just 2 hours, you're done with the hematoma evacuation, done with the AVM. So you are done. So it's just case by case basis. It's just don't have the idea that I'm going to do this all the time. I'm going to do this all the time. And each case is different. But I will wait if patient is stable and hematoma is not causing life-threatening problems. I will wait at least 2-3 weeks.
Thank you. That was the question, actually, to have the cleaner situation for the young guys, because it's yes, you are master and you can do it as emergency big cases, but sometimes we can wait for a few weeks and make the solution better. If I can ask you another question, maybe, if we have some kind of, let's say, dominant hemisphere grade 3 AVM and so, and we see on the angio the deep feeders from the base M1, for example, and so. Have you ever or sometime doing some kind of proximal control? Do you open the Sylvian fissure, find the M1, prepare for the clipping, and then you gonna do the needles to go around and find the smaller feeder? So what about the proximal control for some EVMs?
You have to have the proximal control in every AVM. So if you cannot get that proximal control right on the surface, you get deeper proximal control. Open the cistern, open the fissure, open the whatever you need to do. So always safety, like aneurysm surgery, right? Proximal control, distal control. Same in the AVMs. You have to have a proximal control and see where those feeders are going. That will be your distal control. So it's just physics. Actually, physics dictate whatever you really need to do during the brain surgeries.
Okay, so thanks. So as you say, big craniotomy, go far from the AVM needles if you need, find the proximal control, that back again.
Yeah.
Thank you very much.
Thank you. Great to see you.
Thank you, Professor Ibrahim. I can see there is one question in the chat box from Dr. Timur. Thank you for your great lecture, Professor Mustafa. If you decide to go preoperative embolization, what is the time window? Same day surgery or the next day?
That's very good question. If I do the embolization, only reason I will do for the high flow AVMs, if I worry about the postoperative hemorrhage or normal perfusion breakthrough, I will wait at least 2 weeks to that brain get adapted to the current hemodynamics. If you operate right away, it's the same thing you are doing in surgery, and then you have a hyperemic brain. So you'll wait that brain adapts to that condition at least 2 weeks, and then if necessary do another. So don't do everything at once with embolization too. If you need to do more than one embolization, give time like 2-3 weeks, and then do the surgery 2 weeks. But the case I show you, it was wrong. We embolized the AV fistula part of the direct shunt of the AVM. It caused sudden thrombosis of the large giant varix. So then surgery becomes urgent, right? So just do a little bit embolization if necessary, and then do it again. So don't be very aggressive. If you do embolization 90%, I am telling you that AVM is going to bleed in the next couple of days.
Thank you, Professor. Professor Ahmed, you want to add your comments?
Yes. Thank you, Professor. Mustafa
Thank you.
Baskaya. Okay, salam alaikum.
Yes,
Nice presentation. Thank you very much. I would like to your advice about the low and middle income countries like Afghanistan. That's with limited resources. We haven't possibility to operate on AVM, and we like to know your advice for young neurosurgeon like in Afghanistan about the conservative management. What should we do without surgery? Thank you. Tashakur.
You're welcome. Thank you. Thank you. Shukran. First of all, first goal is to do no harm, right? If you operate and you're going to cause harm, don't do anything. Just let the natural history takes over. But I sincerely urge you and your colleagues, young colleagues, to learn these techniques. It is not high technology surgery. This is all you need is a bipolar, good working bipolar, irrigation, and good suction and microscope. You don't need intraoperative angiogram. You can start doing the simple AVMs first and gain your experience. Also AVM surgery, if you do microsurgery for gliomas, you remove the glioblastoma microsurgically, not like suctioning. That's the best AVM surgery treatment. Because GBMs are like AVMs, but they're just tumors. In GBMs, if you do angiogram, I tell this my young colleagues, they look like a AVM. You don't do angiograms for GBMs anymore. So train yourself in those simple cases, straightforward cases, then you become more efficient, proficient with the more complex cases. Don't give up on surgery. I know you are an excellent surgeon and you teach young colleagues to be excellent like you.
Tashakur. Thank you.
Teşekkür.
So thank you so much, Professor. Is there any further questions from the panelists?
Ben, I'm not sure whether am I audible or not. I'm at the airport. Am I audible?
Yes, session. Yes, I can hear you.
Quickly, I'll ask the question. Professor, thank you very much for the interesting talk. I've been following your videos and the material you post on the Facebook, and it's very interesting. I must say that every time there is some learning points and tips for the young neurosurgeon. I wanted to ask, what is your opinion about normal perfusion pressure breakthrough? Do you agree with this concept, and how do you manage this particular entity?
So I don't know if we should call it normal pressure perfusion breakthrough or hyperemia. I think in certain high flow AVMs, the same principle, like you have one carotid occluded, the other carotid is 99% stenotic, you open this carotid, same thing happens, right? Hyperperfusion bleeds. So what happens in this high flow, large AVMs, the surrounding normal brain capillaries maximally dilated. And you are taking that AV shunt right away. And those maximally dilated capillaries, they don't know what to do. They're not going to go back to their normal size immediately. So that's why his blood pressure control is very important to avoid these problems. And if you suspect anything, the best thing works is the pentobarbital coma for just short period of time until everything normalizes, and keeping the blood pressure. I think it exists, but not as common as described. The most thing we just attribute to this is normal perfusion breakthrough is either there's a residual AVM or poor hemostasis or blood pressure management issues. You will have these bleeds even in the small, low flow AVMs if you don't follow these principles. What I do, after you remove the AVM, you raise blood pressure, you do your perfect hemostasis. Resection cavity looks very dry. You ask anesthesia team to, before you start closing, ask anesthesia team to raise blood pressure artificially to the 140s for 15-20 minutes and observe the resection bed. If there's a bleed, two things: either you left residual AVM or you didn't coagulate well, and as there's those hyperemic vessels, you're going to have a problem. You understand? So you can avoid these problems by either stage embolization, if very large high flow AVMs, and all other things like blood pressure management, emergency pentobarb coma, good hemostasis, and before you close, do this artificial hypertension for 15-20 minutes. If it is not bleeding at that time, it's not going to bleed. Did I explain okay?
Yes, yes. Thank you very much, Professor.
Thank you. Thank you.
Any other questions from any other panelists or delegates? So since it's a young neurosurgeon forum, just wanted to ask, at your place, are you open for the fellowship for the students from other countries? Are you
Yes,
accepting
we are open. We are open, and people start coming. We have a just waiting list. But last few months, the people who are waiting due to the COVID, they start coming, and just send the applications to me. We'll put in the order, and we'll get it.
Sure. Thank you. Thank you very much, Professor.
Thank you. Thank you all. Have a wonderful evening or wonderful day. So thank you for having me. Great pleasure and honor.
Thank you. Thank you. So before we close, before I take the closing remarks from Professor Yoko Kato, just want to mention that our next webinar will be on 26th June. That is, we conduct on 2nd and 4th Sunday. So next one will be on the 26th June, same time. So now I would request Professor Yoko Kato to have a closing remark before we close.
Thank you very much to both speakers. The first young doctor from Riyadh, Dr. Meshari, I think he suggested avoid some complication. Very good, the plan, and also the interoperative some skill, I think they suggested us. And also, of course, the Professor Baskaya talk was very excellent. I think I totally agree. I don't believe the NPPB, which was it was talked by Spencer, I think. But you're so many precise how we can attack the AVM. It was very informative, very, very nice lectures. Thank you very much.
Thank you. Thank you. Domo arigato.
Yes, Domo. So please continue to support the YNS.
Anytime, anytime. You have all my support, training the young neurosurgeons in Asia, all over the world. And we appreciate very much your efforts.
Thank you. Thank you very much. And
thank you.
And Sajid, and also the Professor Howard. Thank you very much.
Thank you. Bye-bye.
Okay.